Hello and welcome to Let's Talk. Today I have as my guest a man who is not unfamiliar to what we do, who has actually become my partner in this process in our effort to make good things happen, not only in Nigeria where we were both born, but in Africa and in the world that we live in. Today we are going to be examining mental health access in Nigeria. And as we do that, we're also going to be discussing some of the problems uh, within that aspect of life, mental health and access to mental health treatment across Africa. He is Sir Paul Inyang, who is a practicing psychotherapist here in the United States, actually in Maryland, and lately has been doing quite an extensive amount of work in Nigeria, trying to bring attention to the need for mental health care and the need to increase mental health care access for the Nigerian people. Sir Paul, welcome.
Thank you very much, Dr. Ohiro. I think you are a pioneer in the business too. So
Yes, I actually should have said that, that in the field, we're actually professional colleagues. It's interesting how we come to this country sometimes not even knowing what some things are, and that's what we end up
the-
practicing, what we end up doing, and hopefully we do it very well. But I would like you to do most of the talking today, if you don't mind. I will just make this a dialogue because it is the field that both of us are in. My question to you is, you are comfortable practicing here in the United States. What is your interest in bringing that expertise to Nigeria?
um, well, my interest is really very simple. There is so much that is not known about mental illness in Nigeria, although everybody would agree that it does exist, and from the highest level all the way down to the grassroots, there's the awareness of how to treat mental health is not there. We do have cultural practices that have been going on since my father's time in terms of practice, but it's what we would call rudimentary practices. It's at the base level, and it's at sometimes borders on being abusive. And so we have a long way to go in terms of creating that awareness of the need for mental health. The other thing that I have noticed recently is that um, as the upper crust begin to acquire some of the diseases that comes from being rich, uh, by that I mean drug treatment. Drugs enter the community, and most often it affects the children of the upper crust. They have begun to see the need for treating mental health services because it impacts them. Uh, most of most of the children are victims of dual diagnosed kids. Rather, it's either they already had the mental health before they experimented on drugs, or their mental health was exasperated by the use of drugs. So, and in seeking treatment for these children, they have become aware of the fact that there are other issues related. And so there is some interest, although not on a global level in the country as it should be. So that was one of the things that sparked my interest. The third issue for me is that, I've been practicing here for now well over 20 something years. And I feel the need to reach out to my people and to be able to do the same thing for my people if I if they would let me do that. And so I've made myself available on several levels. and to see whether I can be part of what is exists now or help improve what exists now.
I like it to go back a little because this is what I'm hearing. It seems to me that you're making a distinction which is somewhat of a subtle distinction, but really you are not saying that it's a very big distinction between psychiatric illness, and when we talk about mental health, psychiatric illness, and substance abuse, and the problems that substance abuse create.
Great.
And you are saying that for both the mental illness, which will be, the things that we know, schizophrenia, schizoaffective disorder, bipolar, depression, and all of those mental illness, mental disorders, you are saying that if we are talking about mental health, we should probably also be looking at that, at problems caused by substance abuse, especially as it relates to Nigeria, where there is now a new socioeconomic class that is rising and now have to contend with substance abuse problems, which really were not thought to be there in the past. Am I paraphrasing you correctly?
Yes, you are. You are really. If I had my way, really, I would like to make a distinction between the two. But I have, over the years, seen that we need to make that association to be able to get the attention of the people who matter or who can put resources into treatment, because their primary interest is very personal. It is very personal for them, in the sense that they are affected by it through their children, and most of those children uh, acquire their illness through drug use. So you try to make that link, to make that link in order to touch the broader issue, which is the mental health aspect of it, behavioral issues and stuff like that, so that you want to bring them in at some point, because they are the ones who are going to either create a legislative agenda for it or put resources into it. Now, for a long time, the global community has been pouring, from what I've discovered, they've been pouring resources into Nigeria, for instance, to deal with the issue of mental illness and drug use. But they too have figured it out that they've spent a lot of money on mental illness and it hasn't gone a long way. So they are making that same association that I'm making, in the sense that they're putting money into the drug use aspect of it, and then backing on that to address mental health issues. So it's really a necessity for us if we are going to look at it. I used to think of it differently, but I have come to understand that you really have to look at them as associates, so that you can really make a point in terms of what we do.
Well, you have said many things that I would like to take you back to, but before then, I want to ask you why you think that despite all of the advances that a country like Nigeria has made, why you think that in terms of mental health treatment, Nigeria is still so backward. Could it be because of the old perceptions of mental illness that existed in that culture?
There are really three barriers to mental illness in Nigeria. One is financial, the other is cultural, and the third is the physical uh, barrier. And the financial aspect is just it's what it is. There isn't enough money put into. They say that 0.03% of the health budget is allocated to mental health. 0.03% of the entire health budget of the nation is allocated to mental health. You know, and so the resources are not there for the grassroots people to address the issue, and neither does the government put enough money into the the whole issue of mental illness. I'll share with you a conversation I had with the commissioner in my state once, and I asked her. I said that I read the assessment for healthcare in the state, and one thing was missing, and that was mental health. Is it that it was omitted, or was it there? Is there a plan to assess mental health as an issue? And she said to me quite simply, she said, "Well, we haven't taken care of those who are mentally right first before we can think of those who are mentally ill." That struck me very much. First of all, it was coming from a professional, and I expected better awareness, and the head of the health institution in the state. So it really that's where where there's no money put or resources put into this mental health. It is I mean, we are fighting an uphill battle. The other issue is the cultural aspect. The cultural aspect embodies many different things. First, the traditional beliefs. Then it also involves traditional treatment. It also involves the stigma associated with mental illness, and also the perception, the shame that comes with mental health in many families. Our cultural beliefs are really really impacts the way we look at mental illness. Because for instance, where I come from, mental illness is not looked at as an illness as such. It is thought of to be a manifestation of wizardry, witchcraft, or sorcery, So, and the treatment is approached thus, where you have either the traditional treatment, you also have the religious treatment, which borrow from each other, and then you have those who are maybe aware enough to know that they need medication to treat depression or other issues related with that. Then you have the physical factor. The physical factor is really the biggest aspect of it. In a country of 150 million, let's say 150 million people, you have 8 psychiatric hospitals. You have 7 training centers for any practitioners of mental health. So, and 17%, I mean, 6 of the hospitals are based in, take care of 17% of the population. There are areas in Nigeria that have nothing related to mental illness. And so you can imagine the stretch that there is. It's impossible to really know how. Let me give you an example of what I'm talking about. In the southwest, there is one in Lagos. In the south, there is one in Calabar. In the southeast, there is one in Enugu. In the north central, which is Kaduna, there is one. And then in the northeast, there is one in Maiduguri. And in the northwest, there is one in Sokoto. Those are the areas covered by mental illness. Then in the upper north, there is nothing at all that exists in mental health.
I think you mean those are the areas where they have psychiatric hospitals located. Okay.
And the psychiatric hospitals they have both inpatient. Some of them have a minimum of outpatient services, but it's mostly inpatient services. The largest hospital that we know of, there are 2. There's one in Edo, which is the Uselu Psychiatric Hospital in Benin. Then there's one in Ogun, which is Aro Neuropsychiatric Hospital. That is the large. The Ogun one has the largest number of beds. They have a 500 bed unit. Facility. The rest do not have much capacity. Uh, so, and most of what they do is they have asylums. They don't really have. It's not a treatment facility as such. It doesn't address it's not a comprehensive treatment. It is, you have people being put into asylums and treated with medication as much as they have resources to get the medication.
Right. I think you mentioned that 0.03% of the Nigerian budget
Mhm.
is allocated to mental health.
Yes.
That's 0.03, which is
Yes.
wow, less than half of 1%.
Yes.
But even within that, 91% of even that figure is directed to hospitals.
Yes.
So, what I would like you to talk about is what you think might be different if two things happened. One, if more money was allocated to mental health treatment, and two, if some effort was directed at providing community health programs that
Mhm.
would address and treat mental health issues.
Therein lies the problem, Dr. Ohiro. That's where the problem. That's really where the problem is. Okay. First of all, I think you mentioned to me the earlier policy, government policy towards mental health it was written in the 1950s.
Yes, it was in 1958, the Lunacy Act. It was really an act by the British colonialists, which actually directed that mentally ill people be
Mhm.
detained and treated, handled involuntarily.
Mhm.
That was in 1958, and then we have had in 2008, well, first in 2006, a bill that was placed and was later withdrawn, and then in 2013, another effort to revive that bill in the Nigerian legislature.
That bill still has not been processed and has not been passed. The last known policy written by the government was in 1991. Okay, and it covered five areas: advocacy, promotion, prevention, treatment, and rehabilitation. Since then, there has been nothing on paper written on the government by the government to address mental health. There is no structure. If you go to the ministries, there is no table for mental health. There's no directorate for mental health in any of the ministries. Okay, so there's no one who really supervises what happens in mental health, in whether it is in the state or the federal level. There is none. So there is no structure for what mental health should look like in the country, other than having hospitals and outpatient clinics that have now begun to pop up a little bit that exists. There is nothing to guide the structure of mental health in the country. And I think that starts with a good legislative agenda that defines what a mental health institution looks like, what it should be defined as, what they call a mental health hospital now. A lot of it's based on you have the hospital component of it. You have the hospital component of it, and it's mostly psychiatric. Like it's mostly psychiatric. It's like an end user facility. That is, no one ends up there unless they have actually reached a crest in their illness. And so it doesn't address awareness in any level, creating an awareness that would allow people to understand when people are having issues, or to address minor issues that don't become a bigger problem. Then there's this aspect of it too. It is mostly adults. There is nothing to address the teenagers, and there's nothing to address children as a whole, you know. So there's no facility for children, if you can understand what I'm saying. Uh, most of here in the United States, it's a bottoms up approach where they begin to address the issues right from the schools and families at the lower level, so that it doesn't get to the point where we reach a crest and there is a problem. But there it is, just it's addressing a crisis, and that crisis is temporary and sometimes does not have enough resource to address the issue.
Let me ask you to speak to the stigma that is attached to mental illness in Nigeria and link that to the current state of access to mental health. Is it possible, for example, that Nigeria has in its government too many people that really do not want to acknowledge that mental illness exists in Nigeria or that it's a problem? And are they also really somewhat enablers of the problem?
Well, there are both enablers and there are two groups of people. One is that you have those who are in denial, and then two, you have those who enable the problem. But in terms of the stigma itself, the stigma is deep rooted. It is deep rooted in our cultural practices. It is one that makes it so that the families do not see mental illness for what it is. They see it as something that is very, very shameful. So they either try to hide it, or they deny the issue is there, or they label it as something else. Now, when you look at when it is being denied, you have families who ostracize the person who has mental illness. If you talk to families, they'll tell you, "Oh, he just talks to himself all day, and he talks to himself all day, and he talks about things they don't understand and stuff like that, you know." And they just avoid them. Uh, when they are physically isolated, they now develop emotional isolation also, and then they end up on the streets as they walk on the streets, and sometimes naked on the streets. And even the people who they are related to avoid them on the streets. They don't get close to them because they're afraid they might be identified. They might be identified by the person, you know. And so that is one aspect of the other part of the stigma is this, you know. It is associated with sorcery and some sort of witchery that goes on within the society. So if someone is ill mentally, it means that somebody did it to them, and there's somebody in the family who did it to them. But it really isn't associated with people outside of the family. It's mostly people within the family. So it says something about the family. So the family is very, very guarded about the issue. And so what they would like to do is export the problem somewhere else. So they label it as something else, and these people end up in not only lunatic, in the hospital by involuntarily, uh, or they end up in the churches. Some of them chained for long periods of time, and in order to get treatment the traditional way.
Let
So,
me just really, I'm glad you mentioned that you went back to that. And there was a 2008 article in the African Journal of Psychiatry, which actually said that 40% of treatment of mental illness um, in one church actually consisted of severe beatings, physical beatings of the mentally ill that were put in their care. Um, I like you to speak to that because for people who are mentally ill, what they do not need is someone beating them up. But isn't there also a mentality in some parts of the society that such beatings will actually beat the evil spirit out of them
Out of
and they'll
yeah.
become well?
Yes. The whole notion of that, as I hear from those who practice it, is that these people have been infected by evil spirits, and the only way to get the evil spirit out of them is to beat the spirit out of them. The other thing, I'll share a story with you. Once I was driving through my town, and I spotted about 12 people sitting on top of a man trying to subdue him. They were trying to restrain him. And I initially wanted to drive by because I understood that, I could be hurt in the process if I did this. But something just told me to stop. So I stopped. And I asked them what was going on. They said that the man is mad, that they want to take him to church and he doesn't want to go to church. And you had people, real strong young men, who were holding this man down, and there were family members who were holding him down. So I asked them, I said, please leave him alone. Just leave him alone for a moment. And they left him alone, not knowing who I was. So they left him alone. And I approached the man and asked him, I said, what is wrong? And the man started telling me his story. And I looked around and told them, I said, please, I'm going to take him somewhere for treatment. Would you people just allow me to do that? And they said, as long as I take him away. So he got into the car and I talked to him. He told me his story. He told me some of the issues that would drive somebody to mental health, depression. They were just ordinary stories that you and I hear all the time in therapy. And so I told him, I said, I'm going to take him to the hospital, whether he was willing to do that. And he said, yes, he would want to. He would like to get treatment. So I took him to the only functioning hospital in my state and I talked to them a little bit, and then they said, okay, that they were going to give him some treatment. And that they had some drugs that I was familiar with. I didn't recommend anything. I just said that whether I just asked them what they had, and they said they told me what they had, and I said, okay, please, can you treat him? And they treated him. He treated him. When I went back a week later, he had left the facility and gone back home. They said. So it is this kind of things that happen. They have to first of all, the treatment is so harsh that nobody ever listens to the person who is mentally ill. Nobody listens to them. There's nobody to talk to them about what's going on. They can't distinguish between acute mental health and one that is just that can be treated, a behavioral issue that can be addressed. So, because there isn't that component all over the country. Now, I was in a hospital in Abuja, in Cairo, General Hospital in Cairo. They have a 30-bed facility, and they have some psychologists working. They have psychiatrists, both psychiatrists and psychologists, who are working with the patients there. It's a new facility, completely new facility. Nobody knows. A lot of people don't know about it, but they say they have 100% capacity in the best 30-bed facility. As it turns out, they are using it mostly for drug and alcohol. It's not really for treatment, but they at least have the counseling aspect of the behavioral treatment care for the patients, and also the psychiatric component. So there are places that are beginning to do things like that, but it's very few, very, very few, and there is a shortage of facilities that do that.
You know that here in the United States, there is really treatment is usually multi-pronged. There is, of course, psychiatry with psychotropics, the medications, combined with psychotherapy. It seems to me that one of the problems with a place like Nigeria, because this is what I have also seen with my work in Ghana, and I'm sure that in many parts of Africa, is that even when there is care in the hospitals, there is in the other piece, which is the psychotherapy to help get them to the point of wellness and to help maintain them. With that in mind, I'd like to ask you two questions. You can answer in any order. One question is, what in your mind would be the ideal treatment access if Nigeria was doing what it should be doing? That's one question. In other words, what would the treatment program be like that you would like to see across that country? The second question is, can you please just fill us in on the things that you're doing or plan to do in Nigeria to bring attention to what we've been discussing today?
Okay, your question is very, very on the point. The what I would like to see happen in Nigeria is a multidisciplinary approach to mental health. Not only should we have the psychiatric component and the behavioral component, we should also have a case management approach also, because there are issues at the grassroots that lead to some of these issues. Let me give you just one issue that I would highlight, and that is domestic violence. The depression, most of the depression that exists in Nigeria is among the female population, especially those that have experienced domestic violence, and they are so beat down that and there's no outlet for them to be able to speak to their issues, or to have people even address them. Because if they go back to family, the family says, "What did you do wrong?" And if they come back to society, the society says, "Well, if you had just behaved yourself, this wouldn't happen." The whole case of blaming the victim, and there's nothing given to the fact that no matter what the circumstance is, that no woman ought to be beaten or even killed. In many cases, as it happens, I see it on these social medias all the time. And so if you were going to address such a person, not only would you have to address their depression, you would have to address the case management aspect of it. What do you do with somebody who has been beaten up? Do you take them out of the family and give them a place to stay and how to feed themselves and stuff like that? The case management aspect of it. Then there is the issue of the depression which they are going through. How do you treat it? Do you use talk therapy in conjunction with medication, or do they have the ability to choose? Choose, because sometimes I encounter people here who will come to you and say, "Well, I don't want the talk therapy. I just want the medication," and it's okay with. I mean, if it works for them, it works for them. So, but they don't have that choice. So it needs to be a multidisciplinary approach that I would like to see. In terms of the work I'm doing in Nigeria, I'm trying to really find a niche in where I can address the behavioral component of the behavioral component of mental health, and also have a psychiatric component also option for people. And if I could also, I would also like to have still the multidisciplinary approach. But where in my trips to Nigeria, the most critical need right now is creating an awareness. It's very critical for people who practice mental health to create that awareness for people about the issue. It's at the level that it is. People can't recognize mental illness. They don't know what mental illness is. They can't define it, and they don't know how to get help. And so there is an awareness that needs to happen. We have tried to set up a conference in which we would highlight some of these issues and bring practitioners from all over the country. Because one thing that has to happen also for it to be effective, we have to also approach the cultural part of it and see how we can customize services to fit the cultural practice, so that it addresses some of the stigma, it addresses some of the concerns of the people at the lower level, so that it brings the language to a point where they can understand it. Okay. Oftentimes, when I go home, I have, for some reason, I don't know who tells them, but they approach me, couples approach me a lot when they're having difficulty and they start talking about their issues. And we talk in local language. We talk about their issues in ways they can understand it. And the thing that they are most worried about is privacy and confidentiality. So, but where does it happen? I would never do that here, which is I treat some of them come to the home to talk to me, okay, and not in an office. Because if you have an identified building that says mental health, one of the things that we realized the trouble we had was that we tried to name our organization with mental illness included. And we were warned immediately that once you mention that word, mental illness, no one will come. So imagine having a building with and with a name on it that included mental illness. No one will come there unless it is in the deep of the night and you are ready to open in the deep of the night, because there is a stigma associated with this. It is such a big aspect of it. If we could address, first of all, we need to get people, at the from the tertiary institutions all the way down to the primary institutions to begin to address the issues that come up. Uh, I give you another example, and that is differentiating between um, learning disorders, and actual mental illness. Things like ADHD and components like that. You go and sit in a school and you see children bouncing off the wall. You see children bouncing off the wall. Nobody addresses it. The only way they address it is they write a letter to the parent and say, we can't take care of you. This child should not come back to school. They can't manage that child. They'll send them somewhere else. There's no assessment to see whether this child has the problem with the child is or how it can be addressed. They just transfer him to another school. And so that's the kind of issues that are real nuts and bolts issues that needs to address. But I think that the key is creating an awareness, a big awareness first. And so I am beginning to think that is the area that we need to start with, because unless people are aware of the problem and how to deal with the problem, then the other stuff is going to take some time, unless we have government support in the process. And as you know, government is everything in Nigeria. The people that fill the loopholes are donor agencies, and they are very careful about where they put their funds in now, because a lot of funds have been put in and has not been utilized for the right reasons. So we who want to do it in earnest just have a difficult time finding resources to do these things.
Well, I am thinking that there may be some stakeholders that we have not even talked about, because if you consider the role of religion
Mm-hmm.
in addressing mental health issues in Nigeria, especially in a society where so much there's so much suspicion and and the devil is blamed for so much, and very often it's not only the traditionalists now, but it's also very often the religious leaders, the pastors, who tell people that the problem that they have, I think you alluded to that before, is really the devil causing it. Uh, don't you see how it can be an uphill battle to convince very religious people that there is another way, and that this way does not mean that they have to give up their religion, but that their belief actually also has a role to play. Their belief systems actually also have a role to play in how they approach and get healing or wellness and maintain all of that. because you can do everything that you are doing, and we can do everything we are trying to do in that culture. But if the pastor is saying, do not take medications because it's an indication that you have no faith, they will not take those medications after you have turned your back.
Yes, it is, you. We need to bring them on the table, on the table. Not only them, but also the people who the spiritualists who actually practice the healing of 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 this. We need to bring them to the table. Now, there is a concept that has been practiced here in the United States, which was designed based on the Central African Republic practices in the central of Africa. Those who speak um, Swahili and that there is an in prior to recently there was this component. The many mental health was defined by two spheres, and that is one, the medicine, the other is the the mind and the body, let's put it that way, you know and the spiritual aspect was never really acknowledged. What it points out to us is that it's a critical component in mental health. The spiritual aspect is this thing. Now I'm distinguishing that from religion. Now, if we could get these people to understand that yes, your personal relationship with whoever you worship or whatever you worship is important in your mental health, without being going into the issue of saying which one is right and which is not right, and just address the issue of spirituality, which is different from religiosity. And maybe we can begin to touch some of these issues as it relates to the way the religious people think of mental health. But Nigeria, in many places, the pastor is the doctor, he is the spiritual guide, he's everything to the parishioners. You find that you have, in fact, I have a friend who lost his wife to ectopic pregnancy based on the fact that his pastor told him that there was that he could pray away ectopic this thing. Now he went to the doctor quite all right, and the doctor said, this is ectopic pregnancy, we need to take it out. He went to his pastor, and the pastor said, I could pray this away. His wife died in the middle of it. Okay. And so this is a continuing thing in Nigeria. It's all over the country, and so we need to begin to address them. But we don't address them by avoiding them. We need to bring them to the table and begin to confront some of these issues and talk to them about some of these issues and give them different perspective. So they have to be on the table. They really have to be on the table because they have so many people in their power. They're under them, that if they say jump, they jump. Whatever the preachers say they do, they do. Because it is not the worship for me as I look at it, and being in my judgmental self, is this, that, people worship people, not the God they went to worship. The pastors are so powerful in the lives of people that you can't ignore them. You have to bring them to the table. So they need to be part of that process of creating an awareness. But I know that there are quite a few pastors who are aware enough to be able to talk about this issue in a way others would listen to. So they need to be on the table too.
Right. I really like to thank you for the time that you have spent with me today. Again, this is a subject that is really, really vast, and we have only just scratched the surface. I would like you to come back very soon to discuss other aspects of this. For example, the role of politics in this, and what advocacy can do, if anything, within that culture to be able to cause the kind of access to happen, that we're talking about. For now, I just want to know if you have any final words before we say good afternoon and thank
Let,
you.
Okay, let me thank you very much, Dr. Hero, for this conversation. But I think that we do need to come back soon and talk about maybe a little bit more specifics in terms of how we address the issue. And that political component is the elephant in the room. It is the elephant in the room. And we need to address it because they decide where they put the resources and how they address problems in the country. And if they don't see it as valuable, it is not going. There's not going to be enough resource for it. So we need to be able to give them something to think about or to get them on board with this issue and look at how that whole issue. I'm interested. I hope we come back very, very soon to address this issue.
Yes.
But I know that I'm more hopeful than ever. When I went home this last time, I was able to connect with some grassroots people who are doing some work. It may not be what I would want to see, but there are people who are addressing the issue, some issues there. And so these people are, I think, are very important people who we can liaise with in terms of addressing the issues that is there. But some of them see, when you begin to talk about the problem, they see you as a threat, somehow. And I don't understand the thinking, but they don't open. They are not so warm to collaborations. And I'm not sure what the reasons are, but I think that we need to. I'm hopeful that we can reach the hearts of these people so that we can begin to address the issues the way it needs to be addressed.
Well, so thank you very much, and we'll talk again very soon.
Thank you very
So,
much.
all right, have a very good afternoon.
Thank you.
Okay, bye bye.